Hello, good afternoon, everyone, and salam sejahtera, salam keluarga Malaysia. I'm Kalai Parisamy, Director for the Institute for Clinical Research at the National Institutes of Health. And it's a pleasure to welcome you to our webinar today on vaccination in pregnancy, safety and booster, and also on the demystifying of booster doses. With me today, I have the pleasure to introduce later Dr. Mrna. He is an expert, a maternal, fetal, and medicine consultant, and also a representative for the Malaysian Obstetric Medicine Society for this afternoon's webinar. Much has happened in the last 2 years with the COVID-19 pandemic, globally as well as in Malaysia, as we are fully aware. And currently, there are already now boosters being offered. And there are many questions being asked. Some of these questions are, what are these all about for booster doses or a third dose? And is it necessary? And there are some criteria for some of you to be given a booster. And there are questions being asked as to whether in pregnancy too, this is a consideration. So it is a pleasure to have both us with a team from the Institute for Clinical Research to host this webinar. And I'd like to remind some of you there who are registered medical practitioners to ensure that to collect your CPD points, ensure you're registered, and that allows us to offer you an online attendance certificate from the team here. And also for questions that are being asked, there's a Slido link where you can type in your questions. And given the time limits, we hope to answer as many questions as possible. At the same time, the webinar will be hosted at the ICR webinar series link. For those of you who wish to recap the discussions today, you can revert back to the link. Let me first start the session, and I will share my slide just to introduce to you where we are in booster and how we can bring this narrative for the next speaker, Dr. Mrna, on the need for booster for pregnancy as well. So COVID-19 vaccine boosters, when and why? And this is a lovely shot of the Institute for Clinical Research being based at the National Institute of Health. And for those of you who wish to come and have a visit, please take the opportunity. There are 6 research institutes here, and for medical practitioners, pharmacists, dentists, it offers a good opportunity to look into research and to have your research facilitated. Now, COVID-19 in Malaysia at current scenario, we have about 2.6 over million cases confirmed, and our death rate is about 1.15, with a total death of over 30,000 over recorded. Now, the majority of them who have had a fatal outcome are those with underlying health conditions. In fact, 70% over of those with health condition are associated with case fatality. And if you look at the age distribution, majority of them come from the elderly, especially above 50 years and above, and certainly 60 years and above becomes a determining age group for being very high risk for fatality, especially for those in our country. Now, in terms of the vaccine rollout, you would appreciate that from the very beginning of the rollout, many portfolios were brought in, but certainly in Malaysia, we used the Pfizer vaccine BNT162b2, the AstraZeneca vaccine 1222, and the CoronaVac, which is the Sinovac vaccine. And from the early onset, we initiated a study to monitor the vaccine effectiveness. And this study is important because it gives us an idea about all these portfolios of vaccines that were brought into the pandemic era to contain the COVID-19 outcome. Now, what we see from this vaccine is that over this duration from about April to middle of September, For those with confirmed COVID-19, the cohort of almost 1.3 million were analyzed against the background of vaccinated and unvaccinated population. And also among those who were admitted to hospitals, all vaccines were seen to be very effective in reducing the risk of ICU admission and death, and also in terms of effectiveness against infection. For example, overall, all vaccines in the national rollout reduce the risk of infection by about 87%, and for symptomatic infection by about 85%. And all portfolios too showed very high levels of protection against ICU admission and of course death. But using that portfolio, we now have a scenario where we can analyze where we are as a nation. Now, if you look at the graph here, it shows for those who have been given a single dose and now completion of doses, up to about the current time, 21st to this month, you realize that the cases that are involved in terms of infection, as well as hospital admission, and for those who are admitted to ICU and death, all of those parameters have seen a reduction from about end of August, early September, and it has now come to a stage where we do not see a huge spike in COVID-19 cases. And that translates to a daily figure of about between 4,000 to 5,000 now, and case fatality rate of around this rate of 1.15%. So this is only possible because of the rapid rollout of the three major vaccine portfolios, Pfizer, AstraZeneca, and Sinovac. And so the benefit of the rapid rollout and all this vaccine is demonstrable through these national data that shows containment of the COVID-19 spread and the outcome for hospitalization and death. Also, from the very beginning of this rollout, the Institute here, we have undertaken zero surveillance studies, and this is to look into the usefulness of this vaccine. So, for example, for healthcare workers in the PIC program, we initiated the use of the Pfizer vaccine. And so from April of last year, if you look into our healthcare workers, one of the first studies we did was to look into whether there was already community spread among healthcare workers, among those who work in hospitals. And we found at that point in time, in the wave one of our pandemic, hardly any healthcare worker who adheres to PPE got infected. And through our sampling, we found there was zero prevalence. This was between April and May last year. And we continued a similar model. And so this work you can reference to our publication that appeared in the Lancet Regional Health to show that high adherence to PPE, in fact, translates to zero prevalence. So when the vaccine was rolled out, we did a similar zero surveillance study. We looked at another larger sample of 551 healthcare workers. And again, healthcare workers were prioritized to receive the Pfizer vaccine. So they were offered this study to be included, and so sampling their blood at certain time points, especially with the timeline that you look forward to see the zero conversion, the neutralizing antibody level. And so we timed this about 2 weeks after the second dose before, and then 3 months, 6 months, 12 months, 18 months, and 24 months. And the blood sample was stored, and when the sample were to be tested, they were thawed, and the serology samples were then determined. At the same time, healthcare workers in our work, we looked at symptoms, and also through hospitals, they have routine testing of healthcare workers. And so you could, in fact, look at symptomatic as well as asymptomatic infected healthcare workers through this serial surveillance work. And the guidelines for those who are deemed positive, you can reference the Ministry of Health guidelines. And for those who have had these symptoms, RT-PCR work was done, and also to trace whether they had any close contact within the hospital and work environment. So we captured the entire contact history of the healthcare workers, and also look at the work environment. Now, this is a result of our healthcare worker that we did this year from this sample of 551. And I'd just like to highlight a few things here. This is the serology result. The first pre-vac one is when before the vaccine first dose is given. Even here, you can see some of our healthcare workers, this is 1 year after the initial work, where there was no conversion. You can see now after a year, there were some of our healthcare workers within our sample who demonstrated a positive antibody level. This is before the vaccine. And then after the vaccine was given, you can see the antibody titer level increased. And 2 weeks after completion of the 2 doses, you can see the antibody titer level against the anti-S1-RBD, IgG level, at the highest level with the kick and test. So 2 weeks after completion of the vaccine dose, this is 3 weeks for the Pfizer, you can see antibody titer levels are at maximum. But over the duration of time for our sample 551 healthcare workers, you could see the mean value starts to wane. Now, this is about 3 months, the blue dotted lines, you can see the spread of it, but the mean titer has started to drop. And also for 6 months follow-up, you can see where they have come, almost to where they started the vaccination. So for this healthcare worker cohort, we can demonstrate that antibody titer does in fact wane over this duration of 3 to 6 months. So this is real data that's come from our work, both at the Institute for Clinical Research and the Institute for Medical Research, in 2 hospitals, Hospital Queen Elizabeth and Hospital Kuala Lumpur. Now, as I mentioned earlier, there were some healthcare workers who are already positive at the point of before vaccination. So we looked at this cohort and compared to those who did not have any vaccine or infection before this. And you can see for those who had prior infection, when they were given the first dose and then the second dose, they had a more robust antibody response. You can see the orangish reddish line here showing the level being constantly higher for those who had prior infection. So someone who has had past infection and then given a vaccine, the antibody level in fact goes up very high. And that is consistent up to the maximum level 2 weeks post-vaccination. And then subsequently too, just like what you saw earlier, the mean titer started to deteriorate overall. Likewise, for those who had prior infection too, although that much higher antibody level, they too demonstrated a waning effect. So it is not only for those who did not have any infection and given vaccines demonstrating waning effect, even those who have had infection and given vaccine also demonstrated a waning effect. What is more clearer now is that the younger population tend to have a better or more robust antibody response as compared to the older or the elderly population. Of course, healthcare workers who are tested were all less than the retirement age in 6 years of age. So we didn't have above 60 for our cohort. And among those who have been vaccinated, again, to demonstrate the antibody titer level, for those who did not have any breakthrough infection, you can see overall 3 months and 6 months, the antibody level deteriorate or wane. For those who did develop infection, for those who are asymptomatic, that means they did not display any symptoms, the mean titer again at 6 months, if you compare 3 months to 6 months, shows that a reduction or waning effect. And until they have a symptomatic infection, only then you start to see the antibody becoming much higher. For someone, therefore, without any symptoms, it doesn't automatically translate to increase in antibody level if one is vaccinated and get infected. Meaning to say that someone has a symptomatic infection, they tend to display a higher antibody response after being vaccinated. Again, you see a difference among how the body responds to vaccination and infection. So in summary, what we have demonstrated from our own study is that antibody level tends to peak about 2 weeks and starts to wane between 3 to 6 months. And during this time, we have seen breakthrough infections. So the rate is about 10%, 8% to 10% overall. And it in fact coincided with the wider community spread. And for those individuals with asymptomatic infection, we don't seem to see a high antibody response. For those with mild symptoms, they tend to have a higher antibody response. And this is no different than many other studies. So this is coming out of the UK work and Wales, where they look at those given vaccines, Pfizer and the AstraZeneca vaccine. Again, the trend, and this is another cohort of about 600 over people, including those with categorized as clinical vulnerable and those with extreme vulnerability, meaning the elderly population. Look at the mean age of 63. Again, in this group too, the titer level tend to wane over the duration, and more than 70 days, you can see now the level, in fact, is actually at a low level, especially for those who are clinically vulnerable. This becomes a problem. And this is another study that we undertook here, the real-world vaccine effectiveness study, quite popularly known as RECOVAM now. Again, in our study, despite the fact the initial rollout of the vaccine in the PIC program showed that the vaccines were effective in maintaining high reduction for ICU and death and reduction in infection. But again, over the duration of 3 to 5 months, we've demonstrated again that vaccine effectiveness against infection has started to wane. This is Pfizer from 88% to 68%, and for Sinovac from about 76% to 27%. So this waning effect overall for the population, despite the fact that it's helped to contain the transmission, as well as the infection, as well as the hospitalization, it is still a problem to reckon with. And this is not unique to Malaysia. If you look at studies that come out of Qatar, US, and UK, almost all of the studies demonstrated the same thing. That for the Pfizer vaccine, it has in fact waned between 78% as high as at the start of the rollout, to about 20% after 4 months. Some have demonstrated as low as 47% after 5 months. So the individual variation, but the trend are almost similar. The waning effect is across the board for all portfolios of vaccines. Now, if you look at some of the outcomes of those who have had infection and then subsequently, as I've demonstrated earlier, being vaccinated otherwise, again, this condition considered that, being infected doesn't offer you long-term longevity of protection correlates as well. If you compare those who are vaccinated and those who are fully vaccinated for breakthrough infection, it is much, much higher among those who are unvaccinated and that recover from infection. In fact, it's 2.34 times. So the odds of you having a breakthrough infection for those who are unvaccinated is in fact higher compared to those who have been fully vaccinated. So again, it shows that being unvaccinated increases your risk of breakthrough infection, even though you're recovered from a prior infection. And some of the data that has come out of the use of the dose, the third dose. So the third dose is given to those who cannot induce sufficient immunity level. And this has come from groups who are immunocompromised, those who are given chemotherapy, and those who have had cancer therapy, and they have radiation exposure, or transplant patient given immunosuppressive drugs. They can't, create sufficient antibody levels as compared to someone given 2 doses and deemed to be healthy. So one of the first work that came out for the third dose for this group showed that, in fact, you can increase those who can seroconvert with the use of the vaccine, and also the antibody level between the first dose and the third dose. You can see how a month later, almost in this cancer cohort, the organ transplant patients, there's an increase in the titer level. So it shows that the use of the third dose is a positive turnover in terms of increasing your antibody titer level. And it's another work that came out from our neighbor Thailand, when they looked at many different portfolios and to combine with other vaccines to see whether they induce higher immune levels. So these are some of those data that you can reference on the CICREST study. So someone given CoronaVac, which is Sinovac, if you add on a vaccine, which is a Sinopharm, or AstraZeneca, or a Pfizer vaccine, you can see that the antibody level almost always increased after 2 weeks when given a booster dose. And if you compare that with someone who's given a Pfizer combination, some of these vaccine boosters are comparable. For example, CoronaVac given the AstraZeneca booster dose, you can see that the titer levels are comparable to someone given 2 doses of Pfizer vaccine. And even between the Pfizer vaccine given to CoronaVac recipients, a half dose is comparable to a full dose. So some of these early data are very good in the way that the discussion about bringing a booster dose was brought into the expert panels. And this is one of the reasons why a heterologous booster was considered effective in increasing antibody levels. And if you look at how the body responds to infection and vaccination, this is a very recent publication in the Journal of Science, where the behavior of the body is very much now related to, at least in this paper coming out of UK, tied to the idea that it's how the first contact with the individual will determine the future response to the body and the need of booster. And again, in this study, looking at a cohort of healthcare workers, they demonstrated that for someone who has a prior infection, the first contact with the vaccine gives a robust response. But again, over the duration of time and the introduction of variants of concern, there's already a reason to be concerned because the antibody level has started to plateau or decrease, despite the fact 2 doses are given, and therefore the need for booster is considered sometimes after 5 months. And in another study that many of these portfolios is mixed and given to people who've been fully vaccinated. This is a boost study ongoing in the UK, where they looked at several different portfolios given to either Pfizer recipient or AstraZeneca recipient. Almost all the vaccines showed increase in immunity level, except for one of the wholly inactivated vaccines for the Pfizer vaccine. It wasn't seen to increase the immunity level. But nevertheless, in this boost study, all vaccines were seen to be safe. There were no red flags for the trial participants. And this was one of the reasons why the UK used this data to roll out a heterologous booster campaign in their use of AstraZeneca or Pfizer for their population. And what is more interesting is that almost all of this combination showed that the side effects were very much more comparable to the second dose of the primary series, no worse than that, and that many of these were very much related to the injection site and or general fatigue and soreness and some nausea. Now, this is coming out from real-world data that was published by the Ministry of Health Chile. It shows that for Sinovac recipients or CoronaVac recipients, and when they offered the use of the heterologous model of boosters, so someone given a complete series of Sinovac, given a Pfizer or AstraZeneca or homologous Sinovac, you can see that the vaccine effectiveness after 2 weeks of the booster dose increased the effectiveness. But this is not across the board similar. You can see that the Pfizer vaccine induced about 20% more compared to homologous Sinovac. And for AstraZeneca, it was slightly less, about 20%. So you can't compare the booster as if it's similar. And one of the reasons for recommending a heterologous booster for Sinovac is based on such outcomes. So I can see the difference between a homologous Sinovac versus a heterologous Sinovac. There are vast difference in the vaccine effectiveness. And also the same for hospitalization. But for death, it is comparable. The difference again for booster doses, almost all booster doses, they seem to have very similar effect on the outcome for mortality. And therefore, if you look at the most recent recommendation for the booster dose, the US now, although initially recommended the use of booster doses for elderly population, those with comorbidities even as young as 16 and above, those living long-term care facilities, it is recognized now that the use of a single booster dose for all individuals 18 years and above is now an eligible condition in the US. And this is approved vaccine by the FDA. And so this is based again on the recommendation of the advisory panel. Something similar is also offered in our country. And again, in the UK, previously they had prioritized the elderly population and those with comorbidities, and this is above age 40. And now you can see that the vaccine committee has recommended that adults 18 years and above are eligible for boosters. Why is this so? All this because it's based on 2 premises. One is that all vaccines have demonstrated efficacy in the rollout, yes, but also there are now demonstrable waning effects. And we know that we can boost the immune level with booster doses, either as a 3rd dose for some who are priority in the cancer group or immunosuppressed group, or those who are healthy but at risk of COVID. Nevertheless, you can still offer a booster. And these are the conditions why a booster dose is offered. And again, there are certain schedules that we can follow. And so in Malaysia now, we have recommended across the board to offer frontline healthcare workers, initially healthy workers too. Now elderly population 60 and above were initially considered, long-term care facilities were considered. We have now brought the age category to eligibility above 18 years above, and especially with underlying medical conditions to be prioritized. Then we added on the recommended population, pregnant mothers, essential frontline workers, especially in the economic sector, and those who have travel restriction to be offered the same. And now all adults 18 years and above are prioritized to receive a booster based on age de-escalation still. And this is a regime of offer of a booster dose. So for a Pfizer recipient, 6 months after the second dose, they can be given a Pfizer as a booster. And if they are contraindicated, they can be offered an AstraZeneca as a booster for them at the 6 months. For AstraZeneca, the Pfizer dose is offered as a heterologous booster, and homologous, they can receive a third dose or a booster dose, AstraZeneca. For Sinovac, we prioritize the use of a Pfizer at 3 months after the second dose based on our data. And also they can receive a homologous Sinovac if they are contraindicated for the Pfizer, or alternatively, they're given AstraZeneca. For Sinopharm, again, 3 months after the second dose, Pfizer. Sinopharm has yet to be given authorization in our country, so they can be offered AstraZeneca as an alternative. For Moderna, we have yet to roll it out, but they'll be offered a Pfizer or a half-dose Moderna or AstraZeneca. CanSino Biologic, which is a single dose, 6 months later to be offered a Pfizer or AstraZeneca. CanSino yet to be given regulatory approval, so we have to wait for it. Likewise, for Johnson & Johnson, regulatory approval still pending. And so we have to wait for that. In the meantime, they can offer 2 months later with a Pfizer and or AstraZeneca. We offered initially 50 years and above for AstraZeneca, but based on most recent data on the safety aspect of AstraZeneca, 18 years and above, they can be given as the boosted dose, subject to risk-harm benefit being articulated to them. And for those who are recommended the third dose, this is the 28 days and above, especially for the priority groups, the cancer patients, those who have chemotherapy, those who are immune compromised. The Pfizer vaccine is given at least 4 weeks after the second dose, especially those with moderately to severe immune compromised individuals. AstraZeneca is 8 weeks after the second dose for the same group, or alternative to the Pfizer. Sinovac, at least 4 weeks after the second dose. But now there's consideration that for all Sinovac recipients, all adults, 90 days after the second dose, we should consider the third dose, and we are hoping that this can become a norm, so that everyone who's given a Sinovac will in fact get a third dose to be considered as part of the extended primary series and to complete the vaccination. So with that, I'd like to thank you why we've given a certain time for booster doses, and the basis why we need to consider the use of booster doses, especially for our country as well. Thank you very much. I will now invite Dr. Muneeswaran to continue the webinar. Thank you.
Thank you so much, Dr. Kale, for setting out the scene and for giving us an overview about boosters and third dose. So, ladies and gentlemen, I'm going to straight move on to a controversial but an important topic, pregnancy and vaccination. And I'm going to justify to you all about boosters in pregnancy. I would like to declare I've got no conflict of interest in this topic. I've not been sponsored by Pfizer or AstraZeneca. So, ladies and gentlemen, in the next 25 minutes, I'm going to talk about 3 things. COVID-19 and the pregnant mother, why we should vaccinate, is it safe? We have got data to say it is safe. And I'm going to show you all and justify why we need to boost pregnant mothers. Ladies and gentlemen, let's first take a look at COVID-19 and pregnancy. Now, what has history taught us about infections in pregnancy? Let's go back 10 years in time. And what have we learned from the influenza pandemic? The amount of mothers who died from H1N1 was highest way back in 2011. The amount of mothers who were actually unwell in the second and third trimester was significantly high. And we realized 2 things. The pregnant mothers are more vulnerable to infection, especially respiratory infections. It was more common in the second and third trimester. And we also highlighted the importance of vaccinating these mothers. It was already known, even before COVID, the fact that if a pregnant mother gets infected, she does not do well. And similarly, we thought those would be the same facts with regards to COVID-19. However, ladies and gentlemen, I would like to show you all this data about implications of COVID-19. Now in US, 148,000 women screened positive. Their death rates were low and their mortality was 0.016%. Now, the UK had one of the lowest maternal deaths in Europe. They only screened symptomatic mothers and the death rate was 0.4%. But in Malaysia, we had 10 times less positive mothers. 184 mothers died as of 31st November. The percentage of mothers dying from COVID-19 is 1.27%, which is far higher than the general population. So ladies and gentlemen, a pregnant mother is vulnerable. If she's pregnant, her risk of dying from COVID-19 is far higher as compared to someone else who's not pregnant. So I believe the early years, we were falsely reassured that pregnant mothers were not infected. The early studies showed that most mothers were asymptomatic, that most mothers had mild disease. But however, ladies and gentlemen, it only took us a few more months, and in May 2020, the truth was revealed that implications of COVID-19 among pregnant mothers was far higher. I would like to bring your attention to this wonderful paper in BMJ, which is a living systematic review. And this paper was one of the largest study up to date, looking into the implications of COVID-19 among mothers in the reproductive age group among pregnant mothers. And yes, ladies and gentlemen, based on this systematic review, we realized that if a mother is pregnant and she gets COVID-19, mortality is increased, ICU admissions are increased, stillbirths are increased, neonatal deaths are increased, neonatal admissions are increased, fetal heart rate abnormalities are increased. So the earlier studies from Wuhan showed they were unaffected. Later, large systematic studies showed that pregnant mothers and their babies were vulnerable. Now, if you think that was only true for the BMJ paper, I would like to bring your attention to another European journal, also a systematic review and meta-analysis. Now, this study showed similar outcomes from the BMJ paper. If a mother gets COVID-19, her need for oxygen support is increased. Her need for mechanical ventilation is increased. Iatrogenic cesarean section to aid respiration is increased. Fetal heart rate abnormalities and preterm deliveries are increased. Now, what if the mother is pregnant as compared to the mother is non-pregnant? Is there any difference? Yes, ladies and gentlemen. Now, this wonderful paper compared mothers who were symptomatic who were pregnant as compared to mothers who were non-pregnant. And the evidence is clear. Pregnant mothers itself were at highest risk. The risk of ICU admissions, ventilation, death, and the need for ECMO was increased purely because one was pregnant, and you can correlate this to the physiological adaptations of a pregnant mother. So, which was greater, the first wave or the second wave? Now, what is the difference between the first wave and the second wave? I believe it is the variant. In Malaysia, during our first wave, we had 0 maternal deaths in Malaysia. But in the second wave, we had a significant number of mothers who died. So I'd like to bring your attention to the ICNAC report, which looked into the number of mothers who were admitted to ICU across England, Wales, and Northern Ireland. And they realized that the second wave, the Delta variant, had far greater implications. And the summarized was, up to 1 in 10 mothers would be admitted to the ICU. But if we had a Delta wave, it is 1 in 7 mothers. So yes, ladies and gentlemen, the amount of mothers requiring ICU admissions can be as high as 1 in 7, which is truly significant. I would also like to bring your attention to another registry specific to be for mothers in pregnancy. It is known as the PrevCoV registry. Now, this is the largest registry created by the University of Birmingham, which still continues to collect data around the globe about pregnant mothers with COVID-19. And they showed that the incidence of preterm birth once again is increased. The incidence of stillbirth is increased. Now, why is the preterm birth increased? Because sometimes if the mother is in ICU requiring ventilation, and has got refractory hypoxemia, the recommendation is to deliver to aid ventilation, and hence iatrogenic preterm delivery is increased. Now, ladies and gentlemen, another controversial part. Everyone asks us, what is the risk of fetal infection if the mother gets COVID-19 near term? Now, the evidence shows that the risk of fetal transmission is actually zero via vertical route, but a perinatal positivity can be as 1 to 2%. So the risk of vertical transmission is none, but the risk of transmission is more towards respiratory droplets and direct contact. So the current evidence shows if the mother is positive, there's a 1 to 2% chance that the baby may also be positive. So with that, ladies and gentlemen, various other publications, a cohort study in California, a cohort study in US academic centers, the inter-COVID multinational cohort study across major hospitals in US, all mimic similar outcomes from the BMJ paper. And even the last paper, which was published last year from the CDC, also showed that pregnant mothers were vulnerable. There was significant increase in implications to the mother's health and the baby's health. Let's take a look at the Malaysian COVID data. Now, based on the Malaysian CEMD data, 44% of mothers who died in Malaysia died due to COVID-19, and the incidence was 184. 60% of them actually occurred in the third trimester, and there were 2 times more mothers who died in 2021 from COVID-19 than the average number of mothers who died in Malaysia due to other causes. So yes, the implications are significant. If you take a look at the timing of maternal deaths in Malaysia, 60% were in the third trimester, but 1/3 were in the second trimester. Again, it ties with the physiological adaptations of pregnancy. So hence, ladies and gentlemen, if a pregnant mother gets COVID-19, the risk of death is 1 in 3 in the second trimester, but most severe in the third trimester. And among all the mothers who died, 66% of them required delivery to aid ventilation. Hence, the incidence of cesarean section and preterm delivery is significant. We often talk about risk factors. So yes, 78% of them had risk factors. One risk factor, which was prevalent across all age groups, was obesity. But I'd like to highlight one fact, ladies and gentlemen. If you think COVID only affects male, it is not true. If you think COVID only affects the elderly, it is not true. Just like why Dr. Kale had showed us that we need to boost people who are above 18 years of age. Based on the Malaysian CEMD data, 60% of mothers who died were young, were below the age of 35. So pregnancy was a risk. Age has got poor correlation with death. So with that, we can summarize that pregnant mothers are vulnerable, especially in the second and third trimester. And this is across the board for all infections, including COVID-19. In the Delta strain, 1 in 7 mothers need ICU admissions. And the risk of death is increased 3-fold if you're pregnant. The risk of ventilation is increased. The risk of mortality is increased. The risk of fetal transmission is 1 to 2%. But the risk of preterm delivery, stillbirth, neonatal deaths, and cesarean section are all increased. The pregnant mother incidentally gets a COVID-19 infection. So with that, ladies and gentlemen, I think we can appreciate that we need to protect this vulnerable group. We need to appreciate that they are vulnerable. We need to move forward and discuss about vaccination in pregnancy. Now here's the Malaysian experience. We first started vaccinating pregnant mothers as early as February, where we focus on the frontliners. And then between April to August, we recommended the vaccination for all high-risk mothers. But quickly, as early as August, we realized that it is not just mothers with risk factors, but it is all pregnant mothers. And hence, we rolled out the vaccination program for all pregnant mothers in Malaysia. And as early as October 13th, we are now recommending boosters for pregnant mothers because 2 doses alone is inadequate just like what was highlighted by Dr. Kali. But let's take a look at the VSafe registry, ladies and gentlemen. Now, this is one of the largest registry in the world. And based on the VSafe registry, as of last week, there were already 177,000 mothers who have been vaccinated in the US, and 6,685 are eligible and are incorporated in the study. I would like to share that I'm proud to say that Malaysia is almost similar to US. We have almost vaccinated 176,000 mothers, and our uptake among pregnant mothers was high as 90%. Although it took a celebrity to drive the message across, I must say that as a nation, we have prioritized pregnant mothers, we have identified them, and our success rate of vaccinating pregnant mothers are far better than most other countries. Now in UK and in US, the total coverage among pregnant mothers was only 30%. But I must say the total coverage among pregnant mothers in Malaysia are as high as 90%. I hope we can achieve a similar percentage for boosters, but that is something that we'll have to wait and watch. So with that, ladies and gentlemen, we know that pregnant mothers are vulnerable. We know that they need to be vaccinated, but how effective is it in pregnancy? So I would like to bring your attention to this paper, which looked into the effectiveness of the mRNA vaccine among pregnant mothers. It was a wonderful study by Dagan et al. And just like non-pregnant mothers, the incidence of breakthrough infections was far lower among those who have been vaccinated as compared to those who were unvaccinated. Hence, the vaccine was effective even among pregnant mothers. Similarly, another JAMA paper by Goldstein also looked into the incidence of breakthrough infections among mothers who were vaccinated. And yes, it was effective. The incidence was far lower in those who were vaccinated as compared to the unvaccinated group. So yes, the vaccine was effective, is effective, has effective, even among pregnant mothers. And the RCOG, the Royal College in United Kingdom, came out with a very strong statement. Back in September, they realized that no pregnant mothers who had completed the vaccine were actually admitted to the hospital, and there were 0 deaths in the vaccination group. Now, I'd like to share the Malaysian experience. Among the 184 mothers who died, 79% of them were unvaccinated, and there were only 2% of deaths in the completed vaccination group. And among the 2%, majority of them had Sinovac. So, ladies and gentlemen, it's clear that the vaccine reduces deaths. It may not be 100% foolproof, but the efficacy and the protection from certain types of vaccines is beneficial, and we can further discuss the need for booster. So with that, let's ask the million-dollar question: are vaccines safe in pregnancy? So perhaps back in February, we were unsure. Back in June, we had a little bit of data. But fast forward November, ladies and gentlemen, I'm going to discuss various studies to show that vaccines are safe. So it's back in June, based on the New England Journal, that we first came out with preliminary findings. And it was clear back in June itself that the vaccines had no safety concerns among pregnant mothers. The VSafe registry patients were followed up, and it was in October that this paper was published. They looked into the association among those who were vaccinated as compared to the risk of miscarriage. Now, the million-dollar question was, can you vaccinate a pregnant mother in the first trimester where organogenesis happens? Now, based on this paper, there is no association between vaccination and miscarriage, even if you were to vaccinate them in the first trimester, as the incidence of miscarriage was similar to the general population across the board for every single gestation. Similarly, 1/3 of the mothers in the UK were vaccinated in the first trimester. Although majority were vaccinated in the second trimester, the 1,428 mothers who were vaccinated in the first trimester did not show an increase in the incidence of miscarriage as compared to the background. Now, for the non-obstetricians in the crowd, the incidence of miscarriage is 15%. It is normal that 1 in 6 women may miscarry purely due to a fetal cause. But if you vaccinate mother, the 15% does not increase. It is the same as compared to the general population. Now, they compared the VSafe registry to 2 other large miscarriage cohorts, and it was clear that the vaccine did not cause miscarriage. Now, question number 2, does the vaccine cause preterm deliveries? The answer is no. Does the vaccine cause small for gestational age? No. Does the vaccine cause infant death? No. Does the vaccine cause increase in NICU admissions? No. The risk among those who were vaccinated among 1,634 women were the same as compared to the background. So now we know that the vaccine did not cause miscarriage, but does the vaccine cause stillbirth? So the US study actually followed up mothers between December to July 2021, and they followed out 11,000 women, and they compared the incidence of stillbirth among those who were vaccinated as compared to those who were not vaccinated. And in the vaccinated arm, they actually had lower incidence of stillbirths among those who were vaccinated as compared to those who were not vaccinated. And in fact, there were only 26 babies who were born stillbirth in the vaccinated group. Now, who are these 26 babies? It was actually not related to the vaccine. One had a tight nuchal cord, one had a true knot, one had an abruption, one, the mother had a medical condition, one had congenital CMV, and one had multiple gestation. So ladies and gentlemen, the vaccine does not cause miscarriage. The vaccine does not cause stillbirths. The cause for the stillbirth were associated with other causes, and the incidence was same, in fact, lower as compared to the background population. Now, how about mothers who were vaccinated in the second and third trimester? So among all the babies who were vaccinated in the second and third trimester, a cohort of 1,574, there were only 45 infants with birth defects. And the incidence was the same once again with the general population. So it was clear, vaccinating mothers in the first trimester did not cause fetal anomalies. Vaccinating mothers in the second and third trimester was also safe. So similarly, a recent paper in BJOC looked into vaccinating mothers in the third trimester, and they showed no adverse fetal outcomes, no increase in NICU admissions, and vaccinating mothers, even in the third trimester, was safe to the baby. So with that, ladies and gentlemen, although the largest series of publications was associated with the mRNA vaccine, this paper was just published a few days ago, looking into the safety of AstraZeneca. And based on this paper, it is also safe to be used in pregnancy. Although the numbers were small, there were no increased risk of miscarriage, there were no increased risk of preterm births, there were no increased risk of adverse pregnancy outcomes. So can you give AstraZeneca in pregnancy? Well, the risk of VIIT is actually highest in the first dose, not the second dose, nor the third dose. And so based on this small study, AstraZeneca is also safe to be used in pregnancy, although the largest data is related to the mRNA vaccine. So what about fetal benefits of vaccination? We often talk about harm. We know it is not harmful, but is it beneficial? So ladies and gentlemen, one of the earlier papers was the ACOG paper, which looked into the amount of antibodies transmitted in the breast milk. And they realized if you vaccinate mothers in the third trimester, the amount of antibodies in the breast milk was far higher in the vaccinated group as compared to those who actually had a natural infection. Similarly, They looked into antibodies in the breast milk. Although they only evaluated a small group of people, they realized that the antibody levels and titers were high up to 40 days in the mother's breast milk after delivery, and hypothesized perhaps there was a little bit of benefit to the fetus. And a recent paper in JAMA compared two things: the amount of antibodies in the serum, the amount of antibodies in breast milk, and the levels were almost similar. So if you vaccinate a mother, especially near towards term, the amount of antibodies which were found in the cord blood, in the breast milk, was significantly high, and perhaps hypothesized the potential benefits of neonates. Although it is not proven, it remains a hypothesis. So that brings on to the million-dollar question: should we give booster or should we not give booster in pregnancy? So, ladies and gentlemen, this paper was just published on the 2nd of November, and it looked into the number that needs to be treated for pregnant mothers. If someone is not pregnant, if someone is healthy, you need to vaccinate a huge amount of people to prevent one death. But if you vaccinate pregnant mothers, you can prevent symptomatic infections in 1 in 206 mothers. You can prevent severe infections in 1 in 400 to 1 in 2,000 mothers. You can prevent preterm deliveries with a number of 1 to 200. You can prevent cesarean sections. Hence, ladies and gentlemen, the number needed to treat is far lower and cost-effective for pregnant mothers as compared to non-pregnant mothers. And that talks to another topic about vaccine equity. It all depends on where a mother lives. And we talk about global reduction of maternal deaths. The amount of mothers who died in Mexico is far higher than the amount of mothers who died in the US. When you talk about prevention of maternal deaths, a simple intervention called vaccination will significantly reduce maternal deaths. If we vaccinated every single mother in Malaysia, we would have prevented 44% of maternal deaths in Malaysia. We would have saved 184 lives of mothers and babies. I would like to bring your attention to this recent paper, which looked into the impact of booster among pregnant mothers. And they evaluated 3 types of mothers: mothers who were pregnant, mothers who were lactating, and mothers who were non-pregnant. They looked into the effect of post-prime and post-boost, and they realized that mothers who were given a post-boost had higher antibodies, had higher titers in the breast milk, had higher titers in the umbilical cord, and perhaps hypothesized that this might be beneficial to the fetus. So, ladies and gentlemen, there's a lot of physiological adaptations in pregnancy. The increase in plasma volume, the change in immunity, the increase in renal excretion. So perhaps pregnant mothers are immunocompromised. Pregnant mothers are vulnerable. The benefits of booster, perhaps the fetal benefits outweighs the theoretical risk. So with that, we came out with a guideline. The guideline in 13th of October recommends booster for all pregnant mothers. Just like what was presented by Dr. Kale, if you had Sinovac and Sinovac, based on the largest safety profile, the recommended booster is Pfizer. So it's 3 months after Sinovac, or it is 6 months after Pfizer or after AstraZeneca. Boosters are safe. It does not cause fetal harm. It is far more beneficial to boost than not to boost. So with that, ladies and gentlemen, we are not the only society or nation who recommends booster. The ACOG recommends, the Australian government recommends. Malaysia came out very quickly with one of the earlier nations to recommend boosters for pregnant mothers. And now the CDC also recommends booster for pregnant mothers. So with that, ladies and gentlemen, I would like to summarize that we should actually fear COVID-19. We should not fear vaccine, which saves lives and reduces death. There's no evidence about safety of boosters, of safety of vaccines among pregnant mothers. It is purely because pregnant mothers were neglected. They were not incorporated in the initial studies. but no evidence does not mean it is unsafe. I think we should appreciate the physiological adaptations of pregnancy, the respiratory changes, the immunological changes, the cardiorespiratory changes makes a pregnant mother more vulnerable. The efficacy of the booster may reduce. Pregnant mothers perhaps may benefit from a boost. I think it's all about the science of probability. It is not always the risk. It is the balance between the benefit and the risk. And ladies and gentlemen, the mRNA vaccines are safe. It does not cause stillbirths. It does not cause miscarriage. It does not cause preterm deliveries. It does not cause fetal abnormalities. I think as physicians, we should be holistic, not just the fetus, but we should think about saving lives. A healthy mother equates to a healthy pregnancy. So with that, I would like to end with a quote. The famous Prof. Muhammad Fatala said, "The women don't die because of illnesses that we cannot treat. They die because society still hasn't decided that their lives are worth saving." With that, I would like to strongly suggest that we should recommend vaccination among pregnant mothers. And I believe this vulnerable group will benefit from the booster. So with that, thank you so much for your kind attention. I'll be more than happy to take any questions if there is. And thank you for your kind attention and for listening to this talk.
Okay, thank you so much for that very wonderful talk, Dr. Muniswaran. As usual, it is extremely exciting to see you bring the evidence and the references that physicians and practitioners can refer in the narrative about the points you're making. And I'm so glad that today we address the anxiety around the booster doses for pregnant mothers, and the data that you shared with us today so clearly points to the benefit. In particular, it's not a single life, you're looking at 2 lives for the benefit of the booster program. And in this afternoon, there are many of them out there who still may have 1 or 2 questions related to this. So please take the opportunity to ask Dr. Muniswaran any specific maternal or fetal related questions. In the meantime, let us address some of those questions that are there. So what we will do, Dr. Muniz, is just run through the questions and see how we can go through. So we start with the first one. I think this is for you to take, Dr. Muniz, first question.
Sure, Dr. Khalid. Adakah dos ketiga mempunyai kesan buruk pada penerima pada jangka masa yang panjang? I think Dr. Khalid, you wonderfully addressed this concern.
Okay, so this one basically, secara amnya, semua vaksin yang digunakan secara booster telah pun dikaji selidik. Oleh itu, dari segi jangka masa panjang, masih dipantau sekiranya ada perkara-perkara yang tidak ditemu semasa kajian. Dan setakat ini kita masih belum ada apa dikatakan sebagai red flag dari segi pemberian booster. Oleh itu, kita buat masa ini tidak ada perkara yang lebih daripada apa yang kita pun sudah tahu. Most of the vaccine have local side effects and some systemic effects, and we continue to monitor. We have one study now under NPRA and the Institute to monitor this called Safe COVAX, and so far we are monitoring this. Next question. Is there any long-term side effect from mixing? So I think this one I shared earlier, the Safe COVAX study, the COVBOOST study from the UK, the secret study from Thailand, and also the real-world data from Chile. And all of them showed the mixing of vaccine, the heterologous mixing, in fact, brings about better vaccine effectiveness. We do not hear from any of these studies that there has been long-term side effects. And I think we need to look into the vaccine effectiveness, especially for reduction in hospitalization and death and reduction in infection. And as I've narrated previously, all of those side effects data come from trials of thousands of population, and also from the real world use of such vaccines. And so we know even from our own country, the AIFI monitoring by NPRA, there hasn't been any red flags specifically for any of the vaccines. Next question, please. So are there any specific comorbidities? I think for pregnancy, I think Dr. Muniswaran, you addressed this. Let me come to the second part.
Sorry, so about pregnancies. So we realized that although 78% of the patients had comorbidities, the most significant comorbidity being obesity, we also realized that a significant amount of healthy mothers actually died in pregnancy. So pregnancy per self is a risk factor. But I think about titers and weaning off, I think Dr. Kale, you'll be the best person to address this.
Yeah, so in terms of the lowering of antibody titers, so we recognize certain populations. We know that those who are given the third dose is in fact for this particular group, those who are immune suppressed or immune compromised, those who have cancer therapy or organ transplant. And so we know in this particular group, these are those specific groups where they are expected to have a lower antibody level. And this is why the third dose is given on about 28 days onwards. Beyond that, we know that it is COVID-related comorbidities are more important as to why one has to be given the vaccine, because we know almost 70% of deaths are related to comorbidity. So anyone with comorbidity, certainly you want to get your vaccine booster taken. Next slide, next question. That is for you, Dr. Muniz.
Yes, so I had a patient who was 27 weeks pregnant, had first dose of Pfizer, then had ATT less than 2 weeks after Pfizer. She developed miscarriage. So, ladies and gentlemen, we are quite certain, based on the evidence, that the vaccination is not associated with miscarriage. Neither was it perhaps related to the Pfizer, neither was it related to the ATT vaccination. So I think it's good to reassess. The most common cause of preterm delivery is actually an infection. So did she have some other underlying cause? It is easiest to blame the vaccine, but some things are coincidental. It is rarely an association. And talking about boosters in pregnant mothers, I believe we should appreciate a few physiological changes in a pregnant mother. The amount of eGFR is increased. The amount of plasma volume in a pregnant mother is increased. So if you expect a pregnant mother to react to a vaccine just like a non-pregnant mother, I believe there are two different cohorts. I believe pregnant mothers were never included in the earlier trials. Only later on, they're slowly being included. So I think it is a space that we have to wait and watch. But the recent paper that I shared, looking into the antibody titers following a post-boost, is extremely interesting. And perhaps we should wait and watch. I believe it may be more beneficial to boost a pregnant mother, perhaps with neonatal benefits. I also like to take this question, Dr. Kale. How do you counsel a pregnant mother post-Sinovac? So the mother actually has got three options. She can take a third dose of Sinovac just because she took 2 doses of Sinovac. But the efficacy of a third dose is only 74%. You can counsel her for Pfizer. It has got the best safety profile. And she's got 2 Sinovacs. The third Pfizer, the efficacy goes up from 74 to 95%. So please give her the benefit and risk. Please counsel her it is okay to mix vaccine. Pfizer has got a best safety profile in pregnancy.
So this question I will take, Dr. Muniz, berapa peratus anggaran dos yang ada pada vaksin booster berbanding vaksin dos 1 dan 2? So this essentially is on the basis that if everyone gets a homologous vaccine booster, then the proportion will remain the same. But of course, for the booster program, we have allowed a heterologous booster. So this proportion will change. So anggaran akan berbeza berdasarkan kepada penerimaan jenis vaksin booster. Contohnya, siapa yang telah pun diberi dos lengkap Sinovac, sekiranya mereka menerima dos Pfizer, peratusnya akan mula berubah dan kita pun dah mengesyorkan supaya diberi contohnya vaksin Pfizer. So not the same as in the primary series. So kita tunggu sehingga data itu lebih lengkap. Adakah dos booster melemahkan daya tahan badan? Tidak. Answer is straight no. Walaupun demikian, apabila diberi dos booster, kemungkinan berlaku rasa lesu, letih dan juga dan sakit yang seperti sedemikian boleh berlaku. Itu tidak bermakna badan itu menjadi lemah. Adalah perbezaan yang jauh. For clinical trial participants in a booster vaccine study, do they require further booster dose? Not particularly. If the booster dose is approved booster dose, then it is considered as part of the series. Of course, this needs to be lined up together with the application for mobility and such in the MySejahtera, which is the trial team will address. Next question. Is there any contraindication, special concern if clients get booster dose slightly earlier the recommended time, let's say a week or 10 days? Actually, they're not contraindicated, but they're not recommended, because many of the things we know now in terms of local side effect or systemic changes occurs because of certain timeline. The data comes from there. So changing this timeline just for a purpose of earlier, it is not going to be, much in the benefit, and therefore they need to monitor more for any adverse event. So we don't want to move in that direction. But there are conditions in which someone can get an earlier dose based on the risk analysis. So for example, we inform that those who are immune compromised, they can take 28 days onwards. So the timing comes together with the data of the trial and the real world analysis. Next, Betty. This for you, Dr. Muniz.
Yes, so can we recommend booster dose in the first trimester? I think in the earlier days, we were concerned about the potential, about the theoretical risk of miscarriage. But based on the New England Journal paper, it is clear that the vaccine does not cause miscarriage. However, it's a combined decision that you and the patient can make. You can advise the patient, you can counsel the patient. The patient prefers to postpone it after the first trimester, it is acceptable. But if the patient thinks it is actually more convenient, it is safer to get the booster, you can give the booster in the first trimester. It does not cause miscarriage. I think
this is a follow-up question from your previous comment. I think it's answered earlier, Dr. Muniz.
Yes, you're right, Dr. Kale. It is always easy to blame the vaccine, but it is good to be holistic and take a look at various other confounding factors.
Okay, next question. Again for you, Dr. Muniz.
Yeah, a 35-week pregnant mother takes a booster. Will this cause a false positive RTK? The answer is no. The booster does not cause a false positive RTK, neither will it cause a false positive PCR. So the best time to boost a pregnant mother will be earlier on in the pregnancy, not late in the pregnancy, but you should not fear that it might cause a false positive test. If RTK is positive, you should treat her like a potentially infected person rather than blame it on the booster.
Do we have the statistics on how many Sinovac first or second dose Malaysian recipients have taken? So this is just ongoing. We started the booster program from October, and this is still ongoing. But of course, there are those who are quite fixed on the idea that they will take a booster which is homologous like Sinovac, and therefore they may forego the offer of the Pfizer vaccine, although the science and the data shows that the Pfizer vaccine has the best safety data as well as the best efficacy data. And so these statistics will of course change as we roll out this program. So at the moment, I'm afraid I'm unable to give the full statistics on this. You have to watch and wait and see how this rolls out. Next slide. Any association of very high antibody levels with serious side effects and myocarditis? No, I think what we are looking at is the associated risk of myocarditis. We know we have seen through some of those papers that the younger population with mRNA vaccine have exhibited a higher risk. But now the data shows across all ages there are increased risk for not only through the COVID infection and disease itself, but also some of the studies that shows across the breadth the risk of myocarditis. What is more important is the risk myocarditis or those events related to COVID-19 itself, which is far, far higher than what is associated with the vaccine. And so it's not about high antibody levels that is the criteria. It's about whether a person responds in an inflammatory mechanism that is different. some of this is not fully explained, and I think recently there was a publication trying to again answer some of the other concerns that were expressed as an observation. So at the moment, no, we can't offer any evidence for this. Yeah, next. I think this is still, the debate is still out there. What is important is we know for the first rollout and all over the world, the booster is brought in on the basis we know now there's a waning effect, although they've been effective in containing infection and reduce hospitalization and death. But to maintain that at the community level now, and also with the VOCs coming in, booster shots would be the way forward. And as to whether for the future this becomes an annual vaccine, like what happens in influenza, otherwise, we will need more data. And it's not uncommon if you see adults who are elderly given annual booster doses for influenza based on the variants that appear. And so let's not go too far into the future until we know whether this COVID-19, the SARS-CoV-2 mutation, is going to either become more endemic and stabilize. This have to be watched and see. Any additional thing on that, Dr. Gunis?
No, Dr. Kali, I think it is a time of uncertainty. You just have to wait and watch and adapt. But I like the fact that you highlighted that boosters were not something new. We have been giving boosters for various types of vaccines, similarly for COVID as well.
Yeah. Okay, good. I think we have answered most of the questions. So thank you very much for all the questions. It's quite interesting to see the thought process, we kind of bring together with this webinar. And also to all those, information sharing from your side, Dr. Muneeswaran, especially on pregnancy-related outcomes, both for vaccination and for booster. And from my side, the research teams here who shared their data on healthcare worker vaccine waning effect, and also from the real-world analysis showing that waning effect is something that requires a booster. And so with that, I'd like to thank you, Dr. Muneeswaran, and also the ICR-IT team and the NIH IT team to facilitate this particular webinar. We look forward to more future engagement, but certainly today has been really fruitful. And to all of you out there, have this session open. You can submit your questions to the ICR platform, and we can try and address it. We will hope to have this posted onto our website, so that you can refer back to this webinar at a time of convenience as well. So thank you all, and have a pleasant day ahead.